Good afternoon and welcome back from your break. We are entering the afternoon session and we will start with Zoster Vaccines. Dr. Lee, are you ready to give the introduction?
Ready to go, thank you.
Thank you. Go ahead, please.
Good morning on the West Coast and good afternoon on the East Coast. I'm delighted to present on behalf of the Zoster Workgroup today. Next slide. First, I wanted to acknowledge the hard work of our entire Zoster Workgroup, including my co-ACIP members Lynn Bata and Camille Cotton, and our ex officio and liaison members and invited consultants. And I especially wanted to call out and thank our CDC lead, Dr. Tara Anderson, for her dedication and leadership of our workgroup during these ever-changing times. Next slide. There have been 41.3 million doses of recombinant Zoster vaccine distributed in the U.S. through the end of 2020 and since October 2017. Although, as noted by our CMS colleagues, I do want to highlight that there have been substantial declines in adult vaccination rates during the COVID pandemic, and including for the RZV vaccine. Would take this moment to just encourage our colleagues to continue to encourage vaccination of all of our adults and children in the U.S. To update folks, the European Medicines Agency approved an expanded indication on August 25th, 2020, and Shingrix is now approved in the European Union for prevention of herpes zoster and post-herpetic neuralgia in adults 50 and older, as well as in adults 18 years of age or older at increased risk of herpes zoster. A supplemental biologics application was submitted to the U.S. FDA to support use in immunocompromised adults 18 years or older to complement what's happening on the European side. Next slide. In October, we presented an update on post-licensure safety monitoring of RZV in both VAERS, the Vaccine Adverse Events Reporting System, and the Vaccine Safety Data Link. In addition, Dr. Anderson presented a rigorous study on the risk of GBS following herpes zoster infection itself. And we had a discussion on the planned benefit risk analyses regarding use of RZV in immunocompetent adults incorporating this new information. Next slide. Since October, we've had 4 workgroup meetings where we've reviewed and discussed findings related to the risk of GBS following vaccination or disease, including FDA assessments on the risk of GBS following RZV using Medicare data, and an RZV Risk-Benefit Analysis, which incorporates this new data on the risk of GBS associated with both disease and vaccination. In addition, we have reviewed and discussed PICO for the use of RZV in immunocompromised adults and the evidence to recommendations framework. Next slide. So the agenda for today's session includes a presentation by Dr. Rich Forshee from the FDA on the risk of GBS following RZV, to complement the VSD presentation from the last meeting, a presentation by Dr. Lisa Prosser on updates to the RZV benefit risk analysis, incorporating new information, and Dr. Tara Anderson will present the workgroup interpretation of the data presented in October and today, and then we will move on to the next scope of work, which is an introduction of the ETR framework for use of RZV in immunocompromised adults, where we know the burden is significant. Next slide. And I just wanted to not only thank the work group and our CDC lead, but also the many CDC contributors. And I particularly wanted to call out our vaccine safety and vaccine economics colleagues who have supported the work group's efforts to ensure that we have the information needed to support a robust and transparent decision-making process. And with that, I'll hand it over.
Thank you very much, Dr. Lee. So we'll go forward then and have Dr. Forshee discuss the risk of Guillain-Barré syndrome following recombinant Zoster vaccine. Dr. Forshee, please.
Good afternoon, everyone. My name is Richard Forshee. I'm the Acting Deputy Office Director in the Office of Biostatistics and Epidemiology at FDA CBER. And today I'm going to be summarizing the results from our study of the risk of Guillain-Barré syndrome following recombinant Zoster vaccine in the Medicare population. Next slide, please. Thank you very much. So the study that I'm going to be discussing grew out of discussions with the CDC. The CDC was conducting a rapid cycle analysis in their vaccine safety data link. And in the fall of 2018, they consulted with FDA on the possibility of doing additional analyses, particularly in our Centers for Medicare and Medicaid Services data. As a result of those conversations, the FDA, in collaboration with CDC and CMS, initiated an assessment of risk of GBS following RZV and Medicare data. There were 4 analyses that were completed. The first was a cohort analysis to replicate the original VSD rapid cycle analysis. I'm not going to talk about that cohort analysis in today's presentation. Instead, I'm going to be focusing on our self-controlled analyses. We did 3 self-controlled analyses. The first used only claims data and focused on the period October 2017 through March 2019. We then conducted medical record review on all of the cases that were identified from the claims data and did a self-controlled analysis using only cases that the medical record review identified as actual GBS cases. Finally, because some time passed while we were doing the medical record review, we extended the time period and did a final claims-based self-controlled analysis for the period October 1, 2017 through February 29, 2020. Next slide, please. Next slide, please. Thank you. So the methods for the self-controlled analysis employed a version of the self-controlled case series analysis to compare the relative risk within an individual. The basic idea behind these is you look at the cases that occur within a pre-specified risk window that might be associated with the exposure and compare that to the cases that occur in a control window where it would be where we do not believe that the exposure could have caused the case. For the population, we used national drug codes to identify the exposures. For RZV, that was October 2017 to March 2019. The outcome was primary inpatient Guillain-Barré syndrome using ICD-10 codes. The population was restricted to those who aged into Medicare and therefore were 65 years or older. We required continuous enrollment in Medicare Parts A, B, and D for 183 days prior to vaccination. And this was to have a clean period with no GBS in the 183 days prior to the vaccination date. The risk window was days 1 to 42 post-vaccination. The control window was days 43 to 183 post first dose. However, this was truncated if they received their second dose before 183 days. Days 43 to 183 post second dose or until the end of the study period, disenrollment, or death. We used a Poisson model to estimate the risk, and the specifications for that are included on this slide. Next slide, please. Here are the results from the first claims-based only self-controlled analysis. For the primary analysis, we looked at all doses. For that, we had 13 cases in the 1 to 42 day risk window. We had 8 cases in the 43 to 183 day control window. Note that the control window is longer than the risk window. So we have a great deal more control days than risk days. When everything is calculated, we had a 4.3 rate ratio that was statistically significant. We also conducted a sensitivity analysis looking at the risk after only the first dose. The risk there was higher with an RR of 9.3, also statistically significant. Next slide, please. Here we're showing the attributable risk in both per 100,000 person years and per million doses. For now, just focusing on the per million doses. For the primary analysis, we had an attributable risk of 6.47. Next slide, please. So in summary, the interim results looking only at the claims base showed an elevated unadjusted rate ratio of 4.3 that was statistically significant. Next slide, please. We then conducted medical record review on the cases. We requested the records for both RZV and ZVL, the Zoster vaccine. We used ZVL in the earlier cohort study. We used the Brighton Collaboration's GBS case definition, and that's fine. We can go ahead and go to this slide. This slide shows the distribution of the 11 adjudicated claims. We see that in the 1 to 42 day risk window, we had a cluster of 7 cases between roughly days 8 and days 16. In the control period, there were only 4 cases spread out between days 84 and 147. Next slide, please. I think this was just going to circle those in the risk window. Perfect. Okay, and so here is the self-controlled analysis using the medical record review. So these were neurologist-confirmed cases. And so in the primary analysis for all doses, we had 7 cases in the risk window, 4 in the control window, for an RR of 4.96, still statistically significant. And an attributable risk per million doses of 3.63, also statistically significant. As we saw in the claims-based analysis, the sensitivity analysis for first dose only had a higher RR and a higher attributable risk. Next slide, please. So here we're showing the results for the extended analysis that went through February 29, 2020. So in our primary analysis with all doses, the rate ratio was now 2.84. This has fallen some from the original analysis that we conducted, and the attributable risk per million doses was 3.13. In our secondary analysis for the first dose only, the rate ratio was 7.72 with an attributable risk of 6.48. We finally had sufficient GBS cases after the second dose to do a secondary analysis looking at second dose only. This came in with a rate ratio of 0.22, but the confidence interval was very wide and included 1. It ranged from 0.04 to 1.22. We did not produce an attributable risk estimate because it was unstable, given the small number of cases and the large confidence interval that we had seen. Next slide, please. So we had several pre-planned sensitivity analyses. None of these led to any substantively different conclusion about the association of GBS with RZV exposure. Next slide, please. I'm going to go into additional slides where we can look at these in more detail, but this is a forest plot showing all of the pre-specified sensitivity analyses that we conducted. And the takeaway message is that for the all doses across the range of sensitivity analyses, the estimates were pretty stable, consistently showing a statistically significant association. The same is true for first dose. Next slide, please. This zooms in on the all-dose analysis, and as I said on the previous slide, you can see that across the several different sensitivity analyses, we had consistent and statistically significant estimates of the association. Next slide. Looking at this by first and second dose, first dose again was consistent across the different sensitivity analyses we proposed, and the second dose only analysis, you can see the relatively large confidence interval that includes 1.0. These forest plots are done on a log scale, just so that people are aware of that. Next slide, please. This was the product of a lot of people contributing to this. I want to thank all of my colleagues at FDA, CDC, CMS, and Acumen LLC, that is the contractor for CMS who managed the data analysis for this project. Thank you very much, and I think that's all of my slides.
Thank you for your presentation. It's now open for discussion. Oh, I'm sorry. Forgive me. I've been informed we're going to wait. Forgive me. Okay, so we'll go forward then. Next presentation. So that would be Dr. Proser on RZV Risk-Benefit Analysis, please.
Great. Good afternoon. I'm Lisa Prosser from the University of Michigan. Thank you for the opportunity to present these interim analyses on the projected risks and health benefits of vaccination against herpes zoster. Next slide, please. The authors have no known conflicts of interest, and the findings and conclusions in this report are those of the authors and do not necessarily represent the official position of the CDC. Next slide, please. The objective of this risk-benefit analysis was to evaluate the projected potential risks of vaccination, specifically Guillain-Barré syndrome, or GBS, in the context of the benefits of vaccination as measured by averted cases of zoster and complications. Next slide, please. Before I start, I'd like to thank and acknowledge all of my collaborators from the University of Michigan, the CDC, and Stanford University who contributed both to the original model and to this current analysis. Next slide, please. This is a modeling study in which we used a previously published simulation model of herpes zoster to project health outcomes incorporating new data on GBS. It's a state transition cohort model, and for this analysis, we modeled cohorts of 1 million each of vaccinated and unvaccinated individuals. Outcomes were projected cases of herpes zoster, including uncomplicated zoster, post-herpetic neuralgia or PHN, ocular complications, death, and the risk of GBS from either zoster or vaccination. We elected not to use cost-effectiveness analysis or quality-adjusted life years in this analysis because the addition of rare adverse events is very unlikely to appreciably change the incremental cost-effectiveness ratio or impact net quality-adjusted life years. Instead, the focus of this analysis was to evaluate the risks and benefits of vaccination by comparing the projected number of incremental cases of GBS with the benefits of vaccination as measured in averted cases, complications, and deaths. Model inputs from the original model were based primarily on published evidence and primary data. For this analysis, 2 new health states have been added to the model for GBS following vaccination or GBS following a diagnosis of herpes zoster. We have also updated the 2-dose completion rates and 1-dose vaccine effectiveness to reflect newly available data. Next slide, please. The analysis compared projected outcomes for 2 intervention strategies: vaccination with recombinant zoster vaccine, or RZV, and no vaccination. The simulation model is stratified by age and can simulate cohorts in 5 separate age groups. Results for all 5 age groups are reported in the base case analyses. We used an analytic time horizon of 20 years, consistent with model assumptions for vaccine durability in the base case. Sensitivity analyses also evaluate time horizons of 10 years and lifetime. Future health outcomes were discounted at a rate of 1.5%, consistent with reported measures of time preference for health outcomes. Sensitivity analyses use alternative discount rates of 0 and 3%. Next slide, please. The next 2 slides show a very simplified schematic of the simulation model. Identical cohorts of 1 million individuals are followed separately through the vaccination and no vaccination arms of the model. Vaccinated individuals can receive either 1 or 2 doses of vaccine, with slightly lower vaccine effectiveness for those who only receive 1 dose. 80% of 50 to 64-year-olds and 86% of those 65 and older are assumed to complete the 2-dose series. Next slide, please. Each year, an individual faces a probability of experiencing herpes zoster illness or remaining disease-free. If they experience a zoster illness, they then have a probability of experiencing complications, PHN, ocular complications, GBS, or a small risk of dying from zoster-related complications. Each year, an individual can also die from other causes in the model. Each of the arrows in the schematic represents a transition probability that is parameterized as a distribution in the model, allowing for the generation of confidence intervals for each of the outcomes shown here. Next slide, please. A new health state was added to the existing simulation model to reflect the probability of an increased risk of GBS following vaccination. As summarized by Dr. Forshee, following the identification of safety signal in the vaccine safety data link surveillance, formal investigations were undertaken by both VSD and the FDA. The first source used in this model is the VSD analysis by Nelson et al. That was presented to the ACIP in October 2020. This study estimates the risk of GBS for vaccination using a historical Zoster vaccine live comparison group. Using chart confirmation, there were 3 GBS cases in the RZV group and either 2 or 3 cases in the ZVL group. 1 case could not be confirmed. Assuming 2 confirmed cases in the ZVL comparison group yields an incremental risk difference of 1.65 per million doses for the pooled single-dose risk estimate. Assuming 3 confirmed cases in the ZVL comparison group yields an incremental risk difference of essentially 0. The mean estimate is 0.16, and the confidence interval is shown here on this slide. This modeling analysis uses the more conservative estimate of 1.65, which assumes there were only 2 confirmed cases of GBS in the ZVL comparison group. The second source is the FDA study just presented by Dr. Forshee, in which the risk of GBS following RZV was estimated using a self-controlled case series approach in a CMS population. For the modeling analysis, we used the attributable risk reported for the extended study period of 3.13 per million doses for the single-dose pooled estimate. Next slide, please. This slide shows the 2 sets of parameters for the risk of GBS following RZV derived from each of these study sources and how they're incorporated into the model. For each data source, the attributable risk of a single first dose and the attributable risk of a completed 2-dose series are estimated and are shown in the light blue rows. For example, in the bottom half of the chart, this lists input parameters from the FDA study source. For individuals who only received 1 dose of vaccine, the risk of GBS is 6.48 per million, and for those who received the full 2-dose series, it's slightly lower at 6.26 per million vaccinees, or twice the pooled single-dose risk from the FDA study. Important to note there are wide confidence intervals across these 2 estimates. For the VSD source data in the top half of the chart, all 3 cases of GBS occurred on the first dose. Therefore, the single dose and the series risk are assumed to be the same for both at 3.3 per million vaccinees. And again, this is a conservative assumption. Next slide, please. This analysis also incorporated a new health state to reflect the possible outcome of GBS following an episode of herpes zoster. The estimates range from 8.6 to 12.8 per million episodes of HC, and confidence intervals are wide. This parameter estimate is based on one unpublished study and also represents a conservative approach to estimating this endpoint. Next slide, please. We conducted a base case analysis reflecting the most likely estimates for each parameter in the model. We also conducted a series of uncertainty analyses to assess the robustness of results to changes in underlying parameter estimates. Next slide, please. This slide reports primary herpes zoster and complication outcomes from the original model for all 5 age groups for vaccinated and unvaccinated cohorts using base case assumptions. For each age group, outcomes are reported for a cohort of 1 million unvaccinated individuals in the upper row and 1 million vaccinated individuals in the lower row. The far right column presents total cases of all zoster-related outcomes, including death. For example, for 60 to 69-year-olds, total cases of zoster are projected to be greater than 128,000 per million for the unvaccinated cohort and greater than 67,000 per million in the vaccinated cohort. Next slide, please. This slide adds projected cases of GBS highlighted in the gray columns. The 2 columns on the left report the projected cases of GBS associated with vaccination for the VSD and FDA-derived parameters, with 3.3 per million vaccinated for the VSD estimate and 6.3 per million vaccinated for the FDA estimate. We're reporting estimates separately for the VSD and FDA data sources because the comparison groups were not comparable across the 2 studies. The highlighted column on the right reports projected cases of GBS following an episode of herpes zoster. Keep in mind that the projected results shown here are for a cohort of 1 million, which includes some individuals, some of whom have experienced HC and some who have not during the simulation period. Next slide, please. This table shows averted cases added to the previous table due to vaccination just for the 60 to 69 age group. For this age group, vaccination is projected to avert more than 46,000 cases of uncomplicated herpes zoster, more than 9,000 cases of PHN, 62 deaths, and 0.7 cases of GBS per million vaccinated. Just a comment that vaccination prevents roughly 48% of cases in this age group, and the proportion of averted cases is lower than the initial VE from the clinical trials due to the effects of waning vaccine effectiveness over the 20-year time period, increasing illness rates with age, and mortality risk, especially for the older age group. Next slide, please. This slide now includes projected and averted cases for all 5 age groups. The averted herpes zoster cases and complications vary by age. Total cases of HC averted are shown in the far right column. Estimates for projected cases of GBS following vaccination of 3.3 or 6.3 per million do not vary by age, as it was not possible to stratify given the small number of events. As reported in our previous modeling study, vaccination yields substantial health gains across all 5 age groups. Next slide, please. And this slide simply summarizes the information on the previous slide. In the far right column, total averted cases of herpes zoster averted ranges from 43,000 to 62,000 per million vaccinated over the 20-year time frame. And cases of PHN range from 5,500 to more than 12,000 per million, depending on age. Averted cases were highest for vaccinated cohorts of 60 to 69 and 70 to 79 years. Next slide, please. We conducted a number of uncertainty analyses. This slide reports only one of them, which shows total incremental cases of GBS and the associated confidence intervals generated using probabilistic analysis for the 60 to 69 age group. So in the far right column, projections using the VSD estimates yield 2.6 incremental cases of GBS per million vaccinated with a wide confidence interval, and 5.6 incremental cases using the FDA-derived estimates. The key takeaway here is that both confidence intervals in the far right column are wide and completely overlapping across the 2 data sources. Confidence intervals were also generated for all of the zoster-related outcomes, and these results were robust to changes in underlying parameters, but not shown here. Next slide, please. So this slide summarizes the balance of potential risks and benefits, now incorporating incremental cases of GBS across both potential sources, vaccination and disease, in the 2 highlighted columns on the left. These vary by age and are estimated to be between 2 to 3 per million vaccinated for the VSD-derived estimates and between 5 and 6 cases per million using the FDA estimates. Averted cases of HC complications and deaths shown on the right-hand side are the same as on the previous slide and demonstrate 43 to 63,000 per million total cases of herpes zoster averted, including 47 to up to 171 cases of deaths prevented, depending on age. Next slide, please. There were some limitations. There was a reliance on unpublished data for key parameters. There were only 3 unpublished studies available to parameterize the new endpoints, and this was further complicated by the typical challenges of characterizing rare events. Because of the nature of the data available for modeling these endpoints, we intentionally took a conservative approach by intentionally making assumptions that would not bias towards vaccination where assumptions needed to be made. Again, we elected not to use quality-adjusted life years as an endpoint in this first phase of the analysis, but we may add these in the next phase of the analysis. Next slide, please. In summary, we evaluated the trade-offs between benefits of averted cases of herpes zoster and complications and risks of rare events by estimating outcomes per million vaccinated individuals. Projected cases of GBS were sensitive to parameter uncertainty, while estimated cases of averted cases of HC, complications, and deaths relied on published data and were less sensitive to changes in parameter input. Thank you for the opportunity to share these interim findings, and I look forward to questions later in the session.
Thank you for that excellent presentation. We'll go on now to the work group interpretation by Dr. Anderson, and then entertain questions. Dr. Anderson, please.
Okay, thank you, Dr. Romero. I will now provide a summary of the ACIP Herpes Zoster Workgroup's interpretation of the available data regarding the risk of GBS following vaccination and disease. Before I begin, though, the workgroup would like to thank the Immunization Safety Office, the Vaccine Safety Data Link, the FDA, and Dr. Lisa Prosser and her team for their contributions toward monitoring recombinant zoster vaccine safety. The workgroup would also like to thank many CDC and other contributors who have provided valuable contributions and insight. Two critical recombinant zoster vaccine, or RZV, safety monitoring updates were shared during the October 2020 ACIP meeting. As noted, serious adverse events have rarely been reported in the Vaccine Adverse Event Reporting System, or VAERS, and RZV post-licensure safety monitoring findings in VAERS are generally consistent with the safety profile observed in pre-licensure clinical trials. For Vaccine Safety Data Link, or VSD, rapid cycle analysis conducted from January 2018 through December 2019, the elevated risk for Guillain-Barré syndrome, or GBS, based on ICD-9 and ICD-10 codes attenuated over time from a rate ratio of 5.25 at the time of the preliminary signal to a rate ratio of 1.24 at the end of the 2-year surveillance period. Results from the final chart-confirmed analysis indicated that the VSD has insufficient evidence to determine if there is an increased risk of GBS following vaccination with RZV. As was presented during the June 2019 ACIP meeting and during today's session, FDA has conducted assessments of the risk of GBS following RZV and Medicare Data in collaboration with CDC and CMS. The cohort analysis, which compared the post-vaccination GBS rate between persons 65 years and older who received RZV between October 2017 and December 2018, and historical controls who received Zostavax between October 2012 and September 2017, identified an elevated adjusted rate ratio of 2.34. Dr. Forshee presented the claims-based self-controlled case series analyses today, noting the primary and medical record review analyses identified a rate ratio of 4.3 and 4.96 respectively, and the rate ratio for the extended analysis was statistically significant at 2.84. As discussed during the October 2020 ACIP meeting, a possible temporal association between herpes zoster and GBS has been noted in a small number of case reports, and one previous epidemiologic study reported an increased risk of GBS following recent herpes zoster. In a CDC-led self-controlled case series analysis using 2 different administrative data sources, we identified an increased risk of GBS 1 to 42 days following zoster compared to the primary control window of 100 to 365 days following zoster, with a rate ratio of 6.3 for adults 18 through 64 years of age, and a rate ratio of 4.1 for adults 65 and older. As noted during Dr. Prosser's presentation today, the RZV Risk-Benefit Analysis evaluated the trade-offs between the benefits of averted cases of herpes zoster and complications and the risks of rare events, and incorporated these new data. Estimated outcomes per 1 million vaccinated individuals included averted cases of herpes zoster, postherpetic neuralgia, and other zoster complications, such as GBS, and rare adverse events, such as GBS. As noted, there are limited data regarding the risk of GBS following zoster and vaccination with RZV. The analysis results show that the projected cases of GBS are sensitive to parameter uncertainty, and the estimates of averted cases of zoster, complications, and deaths rely on published data and were less sensitive to changes in parameter inputs. The Herpes Zoster Workgroup has reviewed and discussed these findings regarding the risk of GBS following vaccination and disease. In summary, the workgroup concluded that clinical trials, observational studies, and the risk-benefit analysis confirm the considerable benefits of RZV vaccination in preventing herpes zoster, severe disease, and complications. The workgroup noted that GBS is rare and that data on the risk of GBS following zoster and vaccination are limited. Based on available data, there was consensus among the workgroup that no change to the current zoster vaccination recommendation is warranted at this time, and that continued safety monitoring of RZV in VAERS and VSD is warranted. Thank you for your time and attention, and Dr. Romero, I'll hand things back over to you for our discussion.
Thank you very much, Dr. Anderson. These three presentations are open for discussion. Ms. McNally, please.
Thank you. I believe my question is for Dr. Forshee. Can you help me understand if the safety review examined whether there was an increased risk because the vaccine was given at a time when other vaccines were administered in that age population?
Yes, we did explore for concomitant vaccination, and we didn't see any evidence that the risk that we saw might have been associated with other concomitant vaccination.
Thank you.
Any other questions or comments? Dr. Paling, sorry.
Hi, thank you guys for a very thorough studies and evaluation of both the risk and the benefit. And so my question is, I know that in adults it's not required to give the VAERS information sheets, but have we included this in that information, or how is this going to be communicated? Thank you.
So this is Rich Forshee. I can't comment on any FDA actions related to this.
Sorry, Dr. Sorry, one moment, please. Would you please repeat the question for us here?
Yes. So I wanted to thank everybody for these analysis and clearly see the risk outweigh the benefit and agree with the decision. At the same time, the question is on the CDC website and in the vaccine information sheets that are given, are we going to, how is it going to be communicated about the rare GBS after vaccine?
Hi, it's Nancy Messonnier. The short answer is it's under consideration, and we're basically working with FDA. So we should have an answer for that within the next, I don't know, right? Hopefully before the next meeting. So we will definitely provide follow-up on that.
Thank you, Dr. Fry.
Thank you, and thank you for the wonderful presentations. I just wondered if there were any intercedent or potentially infections surrounding the time of the GBS that could have contributed to it, and also whether the GBS potentially contributed to any deaths.
Hi, this is Rich Forshee again. We did explore whether other illnesses may have contributed to the GBS, and again, we didn't see anything that would indicate that those potential other illnesses would change the results of our analysis. So we don't believe that it's likely that other illnesses may have led to the finding that we presented. And I'm sorry, what was your, the other question was regarding deaths. we did not analyze deaths following GBS in our study.
Thank you, Dr. Lee.
Thanks very much. I just wanted to add my thanks to all the presenters who I know have spent a lot of time poring over the data. Couple of comments and maybe a question. So, and Rich, please tell me if I get this wrong. I believe the CMS analysis was based on about 1.3 million doses or so. Is that right?
I believe that's correct. Give me a moment and I'll get that exact figure for you.
Okay, thank you. And while you're looking that up, just wanted to comment that, we talked about over 40 million doses being given in the U.S., and that, as has been shown previously with regard to VSD and also just our experience with vaccine safety in general, and my personal experience with vaccine safety in general, having a longer set of, or more data and continuing surveillance, I think is going to be really important to ensure the continued benefit risk balance of the vaccine, but also because we understand that sometimes these risk estimates do change over time. As was seen with anaphylaxis early on in COVID vaccines, our estimates about risk attenuated and similar to the VSD findings. So, I do hope that we'll continue to monitor vaccine safety as a strong recommendation for RZV vaccines. And then I have one more thing, but
Dr. Lee, I have that figure for you. It's a little more than 1.5 million doses were included in the primary analysis in our first stage. So a little more than 1.5 million doses.
Thank you so much. And then just briefly, wanted to also comment that the uncertainty around these estimates, given sort of, we need to continue to ensure vaccine safety surveillance is ongoing, and would be that the risk-benefit analyses really reflect the uncertainty. And I think one of the challenges is, in order to be able to parse through the data, and maybe I'll ask Dr. Prosser if she can pull up that one slide. There's a slide that I think depicts uncertainty in a more robust way than what we can do with one-way sensitivity analyses, that I think could be potentially just helpful in reflecting the great deal of uncertainty around these parameter estimates and how much how important the data is that goes into the model to ensure that we're making the right inferences from these models.
Great, thank you, Dr. Lee. Dr. Anderson, would you be able to pull up slide 23 from the supplemental slides?
Give us just a minute, we're working on it.
Sure. Yes, this one right here, terrific. Great, thank you very much. So what this slide shows, so these are the results of the probabilistic sensitivity analysis. So in 10,000 simulations, where in each simulation, a draw is taken from each of the hundreds of distributions in the model, and outcomes are calculated. And here, so this is the graphical representation of the distributions of those confidence intervals that I showed on the earlier slide, in white for the VSD-derived estimates and in gray for the FDA-derived estimates. And these demonstrate the substantial uncertainty, and this represents the total incremental cases of GBS per million for the 60 to 69 age group. So ranging from below 0 to an upper bound of potentially more than 10 for the VSD estimate, and roughly between 0 and 10, consistent with what we've seen before. But this adds some additional information about what the distribution of those outcomes might look like.
Thank you. Are there any other questions or comments from the liaisons or the voting members? Not seeing any, I think we'll proceed to the next presentation, again by Dr. Anderson, regarding introduction of the evidence recommendations framework for the use of RZV in immunocompromised adults.
Okay, thank you, Dr. Romero. I will now introduce the evidence to recommendations framework for use of recombinant zoster vaccine in immunocompromised adults. The risk of herpes zoster, severe disease, and complications is generally higher in immunocompromised populations, and for some, zoster can be life-threatening. As we will briefly discuss, though, immunocompromised populations are very heterogeneous, both within and across groups. Zostavax, a live attenuated zoster vaccine, was contraindicated for persons with immunocompromising conditions. Recombinant zoster vaccine can potentially address the need for prevention of zoster and its complications in immunocompromised populations. Millions of persons in the United States are immunocompromised. In the 2013 National Health Interview Survey, approximately 7 million adults self-reported immune suppression. There are a total of approximately 3 million among stem cell transplant patients, patients with hematologic malignancies, renal or solid organ transplant recipients, patients with solid tumor malignancies, and individuals living with HIV. In addition to these groups, there are approximately 22 million with more than 80 diverse autoimmune and/or inflammatory conditions, such as lupus, rheumatoid arthritis, and inflammatory bowel disease. These patients often have underlying immune defects, but generally are not considered frankly immunocompromised unless they are on immunosuppressing treatments. Of note, Zostavax was contraindicated for most immunocompromised patients. Regarding current ACIP recommendations for zoster vaccination, the ACIP recommended RZV in October 2017 for use in immunocompetent adults aged 50 years and older. For immunocompromised persons, ACIP recommends use of RZV in persons taking low-dose immunosuppressive therapy, for example, less than 20 milligrams per day of prednisone, or those using inhaled or topical steroids, and for persons anticipating immunosuppression or who have recovered from an immunocompromising illness. Because immunocompromised persons and those on moderate to high doses of immunosuppressive therapy were excluded from RZV efficacy studies, ACIP has not made recommendations on use of RZV in these patients. Several clinical trials of RZV in immunocompromised populations have since been conducted. As Dr. Lee previously mentioned, based on available data, the European Medicines Agency approved an expanded indication for RZV in August 2020. Shingrix is therefore now approved in the European Union for prevention of zoster and postherpetic neuralgia in adults 50 years of age or older, and in adults 18 years of age or older at increased risk of zoster. A supplemental biologics license application has been submitted to FDA to support use of RZV in immunocompromised adults 18 years of age or older in the United States. Regarding the Evidence to Recommendations Framework, or ETR, for use of RZV in immunocompromised adults, the policy question is, should vaccination with RZV be recommended for immunocompromised adults 19 years of age and older? Based on current recommendations and available data for immunocompromised populations, the Workgroup plans to split this question into two parts for those 19 through 49 years and those 50 years and older. For the PICO question, the population is immunocompromised adults 19 years of age and older. The intervention is RZV, 2 doses at least 4 weeks apart, and the comparison is no vaccine. Critical outcomes include preventing herpes zoster and serious adverse events. Important outcomes are also listed here, including potential harms that might be unique to specific immunocompromised populations, such as graft versus host disease or graft rejection. The Workgroup is considering the following immunocompromised populations: hematopoietic stem cell transplant patients, patients with hematologic malignancies, renal or other solid organ transplant recipients, patients with solid tumor malignancies, individuals living with HIV, and patients with primary and acquired immunodeficiencies or immunosuppression not covered in groups 1 through 5, such as autoimmune and/or inflammatory conditions. As previously noted, immunocompromised populations are very heterogeneous, especially considering the range of potential immunocompromising conditions included here and the use of immunosuppressive medications. For the noted groups, clinical trial data is available for groups 1 through 5, and group 6 is included to address other conditions with an increased risk of zoster and complications. Today, we will very briefly address the first domain in the ETR, the public health problem, or zoster and its complications, and the public health importance, given the risk of zoster and its complications in immunocompromised adults. A systematic literature review regarding the risk of zoster in groups 1 through 5 was recently conducted. It was noted that the median zoster incidence estimates for these immunocompromised groups exceeded those reported for immunocompetent adults 50 years and older, and this is depicted in the figure on the right. As you can see, the highest risk was in those who have had stem cell transplants, at times as high as 6 to 10 times the risk of those 50 and older who are immunocompetent. There was variation in study estimates for the cumulative incidence and the incidence of zoster within each group. It was noted that zoster complications and severe disease were increased in immunocompromised populations. However, the data were insufficient to assess risk by group. Regarding risk of zoster in Group 6, included here is a figure and brief summary of findings from a study evaluating the risk of zoster in autoimmune and inflammatory diseases. In this study, the authors determined that there is approximately 1.5 to 2-fold higher risk of zoster in patients with autoimmune and inflammatory conditions than in healthy individuals. It was noted that the risk varied across conditions and by age groups, and age-standardized zoster incidence rates varied, with the highest rate in patients with lupus. The work group has extensively reviewed these and other findings that we were not able to include in today's presentation, and concluded that zoster and its complications in immunocompromised adults is of public health importance. Important points from work group discussions include that immunocompromised populations are very heterogeneous, both across and within groups. The risk of zoster and its complications is generally higher in immunocompromised populations, but again, there is variability across and within groups. It is not feasible to define every possible immunocompromising condition and medication combination, and that it's important to consider broad recommendations and appropriate guidance for immunocompromised populations. Regarding next steps, a more detailed presentation on zoster in immunocompromised adults is planned for the next ACIP meeting, and the work group will continue to review available evidence regarding the use of RZV in immunocompromised adults to address the remaining ETR domains listed here. Specific activities will include reviewing available knowledge, attitudes, and practices data, conducting the grade analysis, reviewing cost-effectiveness analysis data, and updating the ETR framework. As we wrap up the session today, we welcome any questions or feedback from ACIP members regarding the initial ETR framework for use of RZV in immunocompromised adults. And thank you for your time and attention, and I'll now turn things back over to Dr. Romero for our discussion.
Thank you, Dr. Anderson. This presentation is open for questions or comments. Dr. Sanchez.
Thank you. That was very nice presentation. My question is the age. Now, why 19 and over when the supplemental applications to FDA, I believe it's in 18 and over?
Yes, the work group has been discussing addressing the adult immunization schedule, recognizing that within the clinical trials there is limited data for those 18 years of age, and also recognizing the epidemiology of zoster for children and adolescents would be a bit different than adult. So that is our discussion. And also from the standpoint, as I can go back to this slide, just as we were noting for this sixth group, where there are a large number of different conditions that could be included here, there's a lot of variability as well by condition and by age group. So whereas in a condition such as lupus, where there's a significant increase in risk for zoster and complications across age groups for this condition, for other conditions, the younger age groups may not have as much risk. So that's also part of the consideration for that.
It just seems to me that in adolescents and in children, we do see zoster in these populations. I don't know the frequency, but certainly it is an issue. And if it were to be approved for 18 and over, I know it's just 1 year, but it seems to be better to be as inclusive as possible.
I can certainly take that back to the work group for further discussion. Thank you.
Thank you. Any other questions or comments? I'm not seeing any, so thank you very much, Dr. Anderson. And we'll proceed to the next topic, which is influenza vaccines. And Dr. Talbot, are you ready to give the introduction?
Absolutely.
At your pleasure.
Thank you. It's a great pleasure to present the update on seasonal influenza vaccines and seasonal influenza, mainly because it's been a remarkably influenza last year. So next slide. So this is our work group. It's large and an amazing group with 4 ACIP members, ex officio members, and liaison representatives and consultants, which greatly add to the discussion at each meeting. Next slide. So I'm just back one. I'll just do a recap of the influenza session done in October 2020. So at that time, we saw the results from an efficacy study of Flucelvax quadrivalent cell culture-based inactivated influenza vaccine among children greater than 2 but less than 18 years of age, and that is currently approved for ages 4 years and older. We looked at the estimates of influenza burden and burden averted by vaccination in the U.S. during the 2019 to 2020 season. And then we also looked at end of season estimates of 1920 seasonal influenza vaccine effectiveness against medically attended influenza from the 3 U.S. networks, and these include the U.S. Flu BE network, the Hospitalized Adults Influenza Network, and the new Vaccine Surveillance Network in children. Next slide. So current and ongoing workgroup discussions include, so the first one is the proposed update to ACIP influenza statement for the 2021 and 22 season, and that is an ongoing discussion, and that'll be presented in June. And then we are talking about the review of influenza vaccines in older adults. Next slide. So the next topic will be Dr. Grosskopf, who will talk about influenza surveillance, vaccine coverage, and workgroup discussion update. Thank you.
Hi, thanks very much. Good afternoon, everybody. It won't change. Yeah, it won't move. Just a second. There we go. Okay. So thanks again and good afternoon. Before getting started, I'd like to express thanks to the workgroup members who were listed on Dr. Talbot's slide, to whom we're always very, very grateful and indebted, but even more so in what has been a very crazy year. Similarly, I'd like to thank the many CDC participants who support our workgroup activities. Please know that you're all greatly appreciated. So for today's session, we don't have any proposed topics for vote. We'd like to provide the committee with updates on a number of influenza-related topics, including influenza surveillance, vaccine distribution and coverage, and current workgroup activities. We'll start with surveillance. The data on the slides that follow are from the CDC Flu View, the weekly flu surveillance report. We're very grateful to our surveillance colleagues for their work in this data. We'll start out with virologic surveillance. Like the other slides that follow from Flu View, these are data from the latest report, which are current as of the MMWR surveillance week 6, the week ending February 13th, 2021. This first slide covers virologic surveillance and includes data from the National Respiratory and Enteric Virus Surveillance System and WHO collaborating laboratories located in the U.S. All told, this includes about 100 public health laboratories and over 300 clinical laboratories located in all 50 states, Guam, Puerto Rico, and the District of Columbia. Surveillance week is on the x-axis, and the colored bars represent the number of positive specimens broken down by virus type, A or B, and for the public health labs, generally also subtype and lineage. The main point here overall is that the number of positive test results has been substantially lower than what we see in a typical season. Also of note, the black line in the figure on the left, the clinical laboratory figure, which you can see if you look closely at the bottom of that figure, this represents the percent of specimens that were positive. And this is also far lower than is typical for a typical season. As of the most current week, this week 13, only 0.1% of specimens overall were positive for influenza. On the right side, we see a similar chart for the public health labs. These labs typically test further for influenza A virus subtype and influenza B lineage, so there are a few more colors on that chart. But again, overall, the main point is that the number of specimens isolated has been very low. Next, some information on U.S. influenza-like illness activity. This comes from ILI-Net, which is a network of about 3,000 outpatient healthcare providers who report weekly to CDC the percent of outpatient visits that were for ILI. This is a symptom-based definition, not a laboratory-based one, so these are not, the figures that you see here are not all laboratory-confirmed cases. They're ILI cases that are defined syndromically. Surveillance week is again on the x-axis, and the percent of visits due to ILI is on the y-axis. And the different lines represent different seasons, with the current 2020-21 season superimposed with the red triangles. The horizontal line is the national baseline, which is calculated by taking the mean percentage of outpatient visits for ILI during non-influenza weeks for the previous 3 seasons and adding 2 standard deviations. The chief point here is that overall for this season, if you look at that line with the triangles, ILI activity reported by this network has been very low. It's lower even than that of the 2011-12 season, which is the gray line that you can see just above the triangled line, which was another season during which the ILI activity did not break the national baseline. It was a relatively mild season, but this season we have even less activity than then. The next 2 slides summarize mortality data. This first one is from the National Center for Health Statistics. This system uses death certificate data and describes the percent of deaths based on ICD-10 multiple cause of death codes that are coded as being associated with influenza and pneumonia and, beginning last year, COVID-19. The red line represents the percent of deaths due to any of these categories, and the yellow represents pneumonia and influenza-coded deaths, while the blue represents COVID-19-coded deaths. Since this chart shows several consecutive seasons for orientation, just to let you know where the blue peaks begin was about week 10 of last season, so as you look to the right, you go forward in time to the current season. From these data, you can see that the majority of deaths reported to the system were being reported as coded due to COVID-19 rather than pneumonia or influenza. Next, pediatric mortality. This chart summarizes pediatric deaths associated with laboratory-confirmed influenza, which has been reportable in the United States since 2004, by calendar week of death for the last several seasons. Our most recent current season, 2020-21, is on the far right, and for the current season, only 1 such death has been reported. In summary, U.S. influenza activity has been low thus far for the 2020-21 season. The percent of influenza specimens testing as positive, reported by public health laboratories and clinical laboratories rather, is unusually low. Influenza-like illness activity is below national and region-specific baselines. And in addition, though not presented in the previous slides, the cumulative hospitalization rate for laboratory-confirmed influenza from CDC's FluServe-Net is 0.6 per 100,000, which is the lowest reported since 2005 and lower again than the relatively mild 2011-12 season. The basis for this low activity is likely multifactorial, and it's likely that COVID-19 mitigation strategies play a role, things such as use of masks, social distancing, school closures, and there having been less travel or more restricted travel than usual. It's still possible that we'll see increased activity later this season, and importantly, it's not possible to predict the extent and timing of season activity for 2021-22. Next, a brief update concerning influenza vaccine effectiveness. And it's very, very brief. It's in fact only 1 slide. So normally at this time of year, we have a presentation and discussion of preliminary estimates from the influenza vaccine effectiveness networks that CDC has for the current season. Typically the US Flu VE network, but also the hospitalized adult network. Haven is another one that we report. This season, however, due to the low influenza activity, no interim vaccine effectiveness estimates are available. The CDC Influenza Division V networks are continuing to collect available data and monitor activity. However, availability of estimates later this season is dependent upon there being sufficient influenza activity within the networks. So thus far, we don't have anything for this season, and we will report back if we do. Next, we have a few slides summarizing influenza vaccine distribution and coverage. We're grateful to our colleagues in the Immunization Services Division for this information and for helping us put these slides together. So first, we'll start with distribution. This graph summarizes by month, and month is further subdivided into week, influenza vaccine distribution in the United States from the start of the season, and represents actually several seasons here, with the current 2020-21 season being the green line. The current season's distribution has been pretty high. As of February 12, 2021, 193.7 million doses of influenza vaccine have been distributed in the United States this season, which is the highest number of doses distributed in the U.S. during a single season. Next, regarding coverage, there are 4 slides coming up that summarize different aspects of influenza vaccine coverage from different sources, and this data can all be found on FluVaxView. This first one summarizes estimated cumulative coverage from the National Immunization Survey Flu, or NIS Flu, for children 6 months through 17 years of age. Data are shown by week, both overall and by race and ethnicity, as of January 16, 2021. As of this date, estimated overall coverage in this age group was 55%. There are differences in coverage by race and ethnicity, with the lowest coverage being among Black non-Hispanic children at 43.7%, for whom also this figure is lower than compared to the same time last season when it was 49%. Current season coverage is also lower this season than the prior season for Hispanic children at 53.3% versus 56% last season. Current season coverage was similar to last season for white non-Hispanic children at 58.1% versus 57.8% last season. This slide shows coverage estimates for pregnant persons aged 18 through 49 years of age from the Vaccine Safety Data Link. As of December 31st, the most recent date, estimated coverage in this group was 61%, a bit lower than 65% last season. These are coverage estimates for adults 18 years and older from the NORC AmeriSpeak Omnibus Survey as of January 14th through 19th, 2021. They're broken down by age group and race and ethnicity. Missing bars in some age groups indicate insufficient data for that particular stratum. If the sample size was under 30, there's not a report here. Overall coverage for this age group, denoted by the black bars at the start of each cluster, was 53%. This is actually higher than the previous season's coverage estimates for adults, which was 48% by the end of May 2020. As is the case for many seasons, coverage varies with age, and as is typical, is noted here to be higher for older adults at 82% than for younger adults. For example, only 43% among those 18 through 49 years of age. Overall coverage was lower among non-Hispanic Black adults at 44% versus non-Hispanic white adults at 58%. These results differ a bit from just taking them globally from that of children and pregnant women, in that they indicate higher uptake this season as compared with the other 2 indices, which are showing lower uptake. These results are from a rapid type survey, and they'll be compared with results from other surveys later in the season as those become available. So this is one more slide covering an aspect of adult coverage. In this case, it's persons 65 years of age and older, and this is from data released by the Center for Medicare and Medicaid Services on January 9th, 2021. These data show estimated cumulative coverage over time from 2020-21 compared with 1920. As of January 9th, estimated coverage for this season in this age group was 52.7%, slightly higher than 50.2% last season. Next, a little bit of an update on plans for the 2021-22 ACIP influenza statement. So So as mentioned at the top of the presentation, we have no new language proposed for this meeting. Influenza vaccine viral composition for the 2021-22 season will be noted. This is something that we cover every season because most seasons the composition does change. The WHO meeting for the selection of the Northern Hemisphere vaccine viral strains for 2021-22 is slated to conclude today. As of when I checked just before arriving here, it had not been posted yet, but we may hear about that imminently. Discussion of timing of vaccination is something that the work groups discussed recently, in particular as it relates to the current guidance recommending an interval of 14 days between COVID-19 vaccines and other vaccines, since we anticipate that COVID-19 vaccination will still be occurring as the influenza season starts next year. As of right now, we don't have any information to discuss on that, but the work group is continuing to monitor that guidance, both COVID-19 clinical guidance and any additional data that arises. Connected with this subject, there is a study that is being planned by the Immunization Safety Office concerning co-administration of COVID-19 vaccine and influenza vaccine that we can tell you about briefly. And I'm grateful to Karen Broder and Naomi Tepper and those at ISO for providing these slides. So as planned, this will be a randomized trial of simultaneous versus sequential administration of COVID-19 vaccine and influenza vaccine to be conducted at 3 sites: Duke University, Cincinnati Children's Hospital Medical Center, and Johns Hopkins University. The study is funded and is currently in the protocol drafting stage. Enrollment is planned to occur during the 2021-22 influenza season. So we're not going to get any information on this that's going to assist us with plans for next season, but it nonetheless will be very important to do this. Study design may be affected by feasibility considerations in the future, so we'll be describing this further as more is learned. The study will enroll adults 18 years of age and older, including healthcare workers and older adults, and they will be randomized into 2 groups. There'll be a simultaneous group who at visit 1 will get COVID-19 vaccine, the first dose, and influenza vaccine, and at visit 2 weeks later, will not receive a vaccine. The sequential group at visit 1 will receive COVID-19 vaccine, dose 1, and at visit 2 weeks later, will get influenza vaccine. There will be follow-up for reactogenicity and health outcomes for at least 3 months after the last dose of COVID-19 vaccine. Primary objectives include moderate or severe systemic reactogenicity during the first 7 days, as well as other objectives including local and systemic reactogenicity, other adverse events, safety profile by SARS-CoV-2 serostatus at baseline, and immunogenicity. So these are, again, still in development, so some of this might change, but we're looking forward to learning more about it. So our last topic for the update is the review of influenza vaccines for older adults. And this is a systematic review we first brought up a number of meetings ago. And since it's been a little while since we talked about it, we thought it was a good time for an update. Before starting, I just want to thank the folks that have helped us with, but in particular, the review team, my teammates at the influenza division, who have really steadfastly churned through review of quite a few papers in what has been a busy year. So just first a reminder about the context, the reason we're doing this, and the question we're hoping to answer. Older adults, particularly those over 65 years of age, are at substantially increased risk for severe influenza illness, hospitalizations, and deaths compared to other age groups. Unfortunately, this age group also tends to respond less well to influenza vaccines, and vaccines tend to be less effective compared to other age groups. 2 vaccines, the high-dose inactivated influenza vaccine, or HDIIV, and the adjuvanted inactivated vaccine, or AIIV3, were developed and licensed specifically for persons 65 years in age and older and have features that are intended to create a better immune response in this age group. High-dose has a higher dose of antigen, the adjuvanted vaccine has an adjuvant. In addition, there's also the recombinant vaccine, which isn't licensed specifically for 65 and older, it's 18 and older. But high-dose vaccine, adjuvanted vaccine, and the recombinant vaccine have all been studied in this age group compared to more standard, non-adjuvanted, standard dose, inactivated flu vaccines among older adults. And for each, there's at least some evidence of increased benefits in this population. The question for this review is whether the relative benefits and harms of HDIIV, AIIV, and RIV, as compared with one another and with other influenza vaccines, favor the use of any one or more of these vaccines over other age-appropriate vaccines for persons age 65 and older. So just a reminder about what our PICO is for this review. The population of interest is adults 65 years and older. The interventions of interest are trivalent or quadrivalent, high-dose IIV, adjuvanted IIV, or recombinant influenza vaccine. Comparators of interest are other trivalent or quadrivalent influenza vaccines, U.S. licensed or similar, non-influenza control vaccines, placebo, or no vaccine. Primary outcomes for this review, there are a total of 8. There are 4 efficacy and effectiveness ones and 4 safety ones. For efficacy and effectiveness, we are interested in all influenza illness due to any viral type or subtype, influenza-associated outpatient and emergency department visits, influenza-associated hospitalizations, and influenza-associated deaths. Safety outcomes of interest include any systemic adverse event grade 3 or more severe, any injection site adverse event grade 3 or more severe, any serious adverse event, SAE, and also Guillain-Barré syndrome. In addition to these primary outcomes, we also have several secondary outcomes, which we will report if data are available. Those will include for efficacy and effectiveness, any data that's broken down, stratified by influenza viral type or subtype, and for safety, related SAEs, related serious adverse events, those judged to be related by the study investigators. But listed here are the primary outcomes, and these are the ones that are going to be subject to grade. So just to tell you where we are currently, we had the original search done that included citations from January 1990 through December 2019. We had, to date, we've title abstract screened 8,519 reports. Of these, 3,189 reports were forwarded on for full text review. That full text review of those reports has been completed. Marked for inclusion currently, we have 366 reports, including 40 reports of randomized studies and 326 reports of observational studies. These figures might seem high, but one thing to consider is that it's often difficult to discern with certainty from title and abstract whether or not a vaccine of interest was used, because particularly for some older papers and particularly for observational studies, it's not always stated what vaccines were used in the population, or stratified results are not presented. So that leads to us having a fairly large number that went for full text review, and again, a total of 366 studies being marked for inclusion in the analysis. More likely than not, these numbers will change because we will have to resolve some issues regarding whether or not any given study had a vaccine of interest that was addressed. Some studies will be dropped in all likelihood because it's not likely that we're going to have 366 that fit that bill for which we're able to get stratified data based on the vaccines we're interested in. Another reason that some of these numbers are going to fluctuate a little bit is that we do have a few reports, 66 in all, that were referred for full text review but are not currently available. Some are not available electronically, and some libraries are not working at the library and are not able to process requests for full text from their institutions. So we're being mindful of that, and we'll request those later at a more appropriate date. And lastly, another thing that will cause these numbers to change is that an updated literature search has been done to capture papers from late 2019 through currently mid-February 2021. So next steps. We're currently extracting data from randomized studies. We are going to also be processing the citations that are in the updated literature search covering December 2019 through early February 2021. We will be doing quite a few author queries, and we will be eventually doing risk of bias assessments and grade. Meta-analysis will be done for those outcomes and comparisons where there are sufficient comparable data that can be pooled. And we anticipate discussion of this analysis at future ACIP meetings in June and October. So that is all I have for today. Thanks very much for your attention.
Thank you very much for the presentation, Dr. Broskoff. Open for discussion, comments. Dr. Freihofer.
A great discussion, Lisa. Thank you so much. For the next season, will there be any trivalent preparations available, or do you think everything's pretty much going to be quadrivalent?
It's probably best if that's checked for certainty with the manufacturer, but if present trends continue, it would make sense that they're all quadrivalent.
Thank you. Dr. Daly.
Yeah, thanks for that wonderful presentation. I was quite troubled by the data about racial and ethnic disparities in influenza vaccination coverage. And while it's troublesome across all age groups, what really stood out was the disparities in the 6-month to 18-year-olds. So just 2 or 3 questions related to that. That data was based on self-report, is that correct? And if so, have systems been looked at which look at actual vaccination, such as VSD or immunization information systems? And the reason I bring that up is that I think that it's possible that the disparities are even worse, because if there's response bias and Black individuals are less likely to respond to the survey, then I think especially unvaccinated Black individuals, then it could be that the disparities are even worse than we see in self-report.
Yeah, hi, this is Dr. Messonnier. Maybe I'll just reply by saying that we remained quite concerned about those disparities. We do believe that the disparities are genuine. I think Dr. Grosclose, who is an influenza expert and not the immunization coverage SME, probably is not prepared to go through that in great detail, but we're happy to discuss it with you offline, and certainly happy to come back at the next meeting and present on that. I think we have presented it before, but certainly happy to come back on that. Thank you.
Thank you, Dr. Messonnier. Anything else to add, Dr. Grosclose? No. Okay.
No, I have nothing further to add. Thank you very much.
Dr. Bernstein.
Clear and concise presentation as always, Lisa. I just had a question of those modest number of flu viruses that have been circulating. How well do they match with the vaccine this season?
Oh my, that is a very good question, but the numbers are so low as to probably make it not reasonable to draw any conclusions from it. I'm happy to take that back and find out if surveillance has any further information, or if Dr. Alicia Fry is on, she might be able to address it further. But the numbers are so low, and you could see even in the public health laboratory. Another question that's come up is, is there more H3? Is there more B? It's not possible to tell. I mean, it's such a small sample size.
Thank you.
Any other questions or comments from the work group or the liaison? I'm sorry, for the voting members or the liaison. Oops. Okay. We have one more presentation, which is work group considerations.
Oh, that
was rolled into that?
That was it, yes.
Okay, good. Thank you.
Yep. You rolled them together.
All right. So now we're due for a break. And let me check with Dr. Cohen to see, we're running ahead of schedule. Let me see how many minutes she wants to give us. Okay, so we will give you a 15-minute break, and we'll resume at 10 after the hour. Thank you.